Great. Well, hi, I'm Erin Parkinson. I'm a nurse practitioner with Tampa General Medical Group Transplant Institute. I work in general hepatology and transplant hepatology, and I'm so glad you could join us. We're going to be talking today about differentiating stage 3 and 4 fibrosis in MASLD. All right, so we're going to start with a case study. This is Sam that we're going to be talking about. He's 55 years old. He was referred for mildly abnormal, liver function tests. He had an abdominal sonogram that just showed increased liver echogenicity, and he complains of fatigue. So this is quite a classic patient that we see every day in the office, right? 55 years old. He's Caucasian. He has a BMI of 33, so he is obese. Classic patient. In terms of medical history, we can see that he has metabolic syndrome. So we have diabetes, hypertension, hyperlipidemia, sleep apnea. He's got the whole bit. No alcohol use, so that's good. We do a physical exam. He is obese, but there's no stigmata of advanced liver disease. He has no hepatosplenomegaly on exam. Medications are pretty, classic as well. I mean, he's on an ACE inhibitor, so he's on lisinopril. He is on a statin, rosuvastatin, and you can see the others listed there. And being on a statin is just fine. We prefer that patients are on statins, actually, for the most part, because it'll help control their metabolic syndrome. All right, so we have our vitals, we have our labs. Vitals, he's a little bit hypertensive despite the lisinopril. BMI we talked about at 33. His AST, ALT are just mildly elevated, 72/85. That's also very classic for MASLD. He has a Billy of like 1.17. Now his platelet count of 157, I consider that a poor man's biopsy. So, if you start getting around platelets of 150,000, I'm concerned about advanced liver disease. Of course, there are other reasons to have low platelets, but in a hepatology clinic, the reason is, cirrhosis and portal hypertension. So he's 157, he's a little bit above that cutoff, but I'm definitely starting to think, am I a little bit more concerned about him? His A1C is not great, it's at 7.1, so of course he has some room for improvement. Creatinine's okay, 1.1. He has a normal INR. We do screen him for other reasons to have chronic liver disease, as we should. We do some iron studies, and the ferritin of 780. Am I worried about that? I'm really not. I mean, first of all, his iron saturation is 30%, and it's very common to have elevated ferritins in the setting of MASLD. Same can be said for this ANA that came back positive at 1 to 80. An ANA of 1 to 80 is really not positive, and it's common to have these positive low-level, low-titer ANAs in the general population and in MASLD. But the smooth muscle antibody was negative, and then our viral hepatitis panels are negative, including the Hep B surface antibodies, which means that, really we need to encourage Hep B vaccination. I don't see that we checked for Hep A immunity, but I would also check for that. So most likely, what's our diagnosis? Our diagnosis is most likely MASLD. We have a fatty liver on ultrasound. We have all the risk factors for MASLD, and we've ruled out other reasons that he could have liver disease. So, we want to know how worried we should be. We need to be able to stage him, and we have all different ways that we can do that, from, less complex to a little bit more, involved or more costly testing. The first thing to do is a Fib4, and generally that's something that really should be done more in like a primary care office or an endocrinologist when they're trying to determine, does this patient need to be referred to a specialist like a hepatologist or GI office. So the Fib4, as you know, it's just, AST, ALT, platelets, age, and it gives you this reading. And it goes from low risk, intermediate risk, and high risk. Now, of course, what we get is something kind of in the middle. So his is 2.74, which falls in the category of intermediate risk. So we're concerned enough that he needs more testing. So if something falls in intermediate or high risk, we really need to do something else. And the next logical step would be a FibroScan, which hopefully we have access to. It looks like we did. And we're just looking at staging with the kilopascals. That's the stiffness of the liver. And his comes back at 11 kilopascals, which that puts him in stage 3. So that's significant fibrosis. And stage 3 fibrosis is advanced liver disease. It's not quite the cirrhosis. It is important that we try to distinguish the two, because stage 3, number 1, is reversible. So even though we have bridging fibrosis, that can be reversed if we can control what's causing it. Prognosis, conversations we're having with the patient, what other things we need to be doing for him. We also get the CAP score, so that's the amount of steatosis or fat in the liver, and his comes back at 262, which is moderate. So, again, it confirms our diagnosis of fatty liver disease and, or metabolic associated liver disease with MASLD. Now, another option that we have could be an ELF blood test. This is commercially available. It's not something that I use in clinical practice. I've used it when we've been involved in clinical trials. But some people do utilize it, and his came back at 9.9, which actually is a little bit above the severe and, not quite to cirrhosis, which would match up for a stage 3 patient. So what would we do? Do we have any further testing we want to do for him? When I start getting results that are stage 3, stage 4, I typically do an MR elastography just to make sure that that's what I'm dealing with. I also do that because although our FibroScans are good, I do get, variable results sometimes. Sometimes I get results that don't make sense. This one makes sense. It didn't give us the IQR for that FibroScan, which is important because that's like the variability of the measurements so that we know how reliable it can be. So any further testing, I would consider an MR elastography just so I can have the right conversation with the patient and make sure that there is not, in fact, cirrhosis and that I am dealing with stage 3. But ultimately, how would we stage with the information that we have? He would be stage 3 fibrosis. So he has what's considered advanced liver disease. It's not quite cirrhosis, and we need to figure out what to do with him. So what would we do? What are our treatment options for this stage 3MASLD patient? Well, number 1, we need lifestyle modifications, right? So that's going to be really important, regardless of medication that we might be able to give. So we have to have conversations, in-depth conversations about diet, preferably like a Mediterranean diet, but anything where we can get some weight loss, that's going to be really important. Talking about little changes maybe he can make in his diet. Control of his contributing factors. So he needs better control of his diabetes. Looks like his blood pressure could use some improvement. We don't have his lipid panel, so we don't know how controlled he is on the rosuvastatin. So we need to be controlling all of those things. And then, what about medications? Do we have options for him? And fortunately, we do. So if we've confirmed stage 3 fibrosis, then, we can use Resmetirom. So we have a medication that's indicated for stage 2 to 3 fibrosis. That's, Rezdiffra. And that would be a conversation. And with my stage 3 patients in particular, I'm really aggressive. Like, we have an opportunity here to try to prevent progression to cirrhosis and hopefully make this better. I emphasize the reversibility of the fibrosis and the steatosis, try to really motivate the patient. The other thing that would be a really good option to consider would be a GLP-1, either in addition to resmetirom or separately. It doesn't have to be one or the other. It can be both. But the GLP-1, obviously the benefit is we can perhaps improve his diabetes some, hopefully trigger some weight loss. And, there are studies coming about, how effective the GLP-1s would be for just treatment of MASH in general. So we have a good treatment plan. We've got lifestyle modifications. We have some control of his other diseases that are contributing to his liver disease. We've got medications that we can offer him. And, so he has some things that he can actually do. And then how would we monitor him? So, first of all, if he started on Resmetirom, then there are some guidelines by AASLD in terms of monitoring when the patient is taking that medication. So I would go by that. I would be monitoring, his liver enzymes, although it's not always reflective of inflammation. He does have some elevated enzymes to begin with. So if we see those come down, that could be reassuring. And then I would be doing annual staging modality. So FibroScan is what I've done for him, and that's what seems to be effective and accurate for him. Then I'm going to repeat a FibroScan in a year, regardless of what I'm doing in terms of medication, because it's important that we're really tracking his fibrosis and looking for disease progression. Longitudinal, non-invasive measures of fibrosis are really more accurate than just one time. So a one-time FibroScan, yes, it's helpful. It's like a snapshot. It's one tool that I'm using to put all the puzzle pieces together to try to stage someone, but it's more reliable the more history we have. So if we're doing those tests annually and we can see that we're getting similar results every time, which gives us it makes us think it's more reliable. And then we're also looking for progression or improvement in the disease. The other thing that we need to do, and it's listed on this slide, is we do really need to screen for HCC. So although it's, technically stage 4, cirrhotic patients are the ones that are recommended to have the every 6-month screening. Stage 3, we really need to be doing that as well for MASLD patients. There is an increased incidence of HCC in non-cirrhotic MASLD. It's just not enough yet that they would, based on cost benefit, all of those things, that they would recommend it. But my stage 3 MASLD patients, I am doing at least ultrasound and AFP every 6 months. Okay, so now imagine the same patient profile, all of these things, same guy. Medical history is the same, metabolic syndrome, the physical exam is the same, so no stigmata of advanced liver disease, but we have some different results for labs. So vitals are the same, liver function tests, the liver enzymes are the same, but now we have a Billy that's 1.4, not quite normal. We have a platelet count that's 128,000, so poor man's biopsy, we're less than 150,000, I'm worried. Again, A1C is not great. INR is normal, so that's a good measure of synthetic function for the livers. That's what I'm looking at to determine, that in combination with albumin, that's what I'm looking at to determine how well the liver is actually working. So that's reassuring. Creatinine, is not normal. We're talking 1.3. I know that's not crazy. People who work in primary care offices, that's a pretty standard creatinine, I'm sure that everybody sees. But patients with liver disease, it is really important when we're looking for evidence of CKD. All right, so same patient again, but we have those lab values that were a little bit different. And now we have different non-invasive testing scores, which doesn't surprise me, right? So again, starting with a Fib4, probably through the primary care office, this patient comes back as high risk, not surprisingly. So 3.36, greater than 3.25 is high risk. And then our FibroScan results are quite different. So the stiffness comes back at 21 kilopascals. So that's cirrhosis. Greater than 12.5 on this particular FibroScan is indicative of stage 4, and we're at 21. So that's a stiff liver. That's someone that I'm worried about. CAP score, so looking at steatosis, it actually comes back at 245, which would be none or mild steatosis. And, that's also not surprising to me. What these patients end up getting is burnt out MASH. So oftentimes you don't even see the fat anymore because it's all been replaced by scar tissue. So even if you did a liver biopsy, they would say, etiology cannot be determined based on this sample. However, based on clinical picture, would consider, MASLD as one of the differentials. So not surprising that there really wasn't any significant amount of fat that was found on that. And then again, the ELF blood test coming back at cirrhosis, 11.4. So now we have a patient who, I believe the FibroScan because I have a platelet count of 128,000. I have a bili that's just a little bit up. So I've got the things that would make me suspect that there's cirrhosis, and I have a FibroScan confirming it. In some cases, I'll still get an MR elastography. I mean, we probably order a lot more of those than other places. Again, just to confirm, this is also a different conversation you're having with the patient. I mean, yeah, stage 3 fibrosis, it's obviously serious. We have serious conversations, but if I'm talking prognosis and what does this mean? And when you throw around the term cirrhosis, that's, really impactful to patients and their families. So, I do like to make sure, of course, that that's what we're talking about. So, how would we stage the patient? It would be stage 4 fibrosis, which is cirrhosis. How would we treat this patient? Well, same thing, lifestyle modifications. We're not going to change that. So still needs to change the way he's eating. He needs to exercise, 150 minutes a week of moderate intensity exercise. So that Mediterranean diet, of course, and I didn't mention it before just because it says he doesn't drink, but reinforce absolutely no alcohol. There is no safe amount of alcohol in cirrhosis. And now treatment. So technically we don't have resmetirom. So, that's indicated for stage 2 and 3. We don't have an indication currently for cirrhosis. So that's not an option. We still could give a GLP-1. So that can be used in cirrhosis, and that would still give him hopefully improvement in his diabetes and his weight. Monitoring. In terms of monitoring for this patient, of course, we need our HCC screening. So we're going to do our imaging every 6 months along with an alpha fetoprotein. And I would generally see them in the office every 6 months with those results to review. Now, the other thing we need to think about and do for this particular patient is screen for clinically significant portal hypertension. So for this patient, this is someone who traditionally we would say, you have cirrhosis, you get a screening endoscopy, period. We're looking for varices. Now we have other criteria we can use rather than sending everyone for a screening endoscopy. And I'm going to back up a little bit. So we have a FibroScan result with 21 kilopascals. And you remember the platelet count of about 127,000, I believe. And based on criteria, if you have kilopascals that are 20 to 25 with platelets less than 150, that's diagnostic for clinically significant portal hypertension. And the recommendation is that we start him on carvedilol. Now, based on his blood pressure, he does have room for that. So that's not going to be an issue. We do the carvedilol, not really specifically to prevent varices, but we're trying to prevent actually decompensation in this patient. So carvedilol has been shown to decrease the incidence of decompensation of liver disease, and it also improves all-cause mortality. So here we have it, diet and lifestyle, monitoring for HCC. We need to screen for varices, but as I said, it doesn't necessarily need an EGD because we can use the non-invasive measure to determine that there is, in fact, clinically significant portal hypertension. Now, these are our two patients, just kind of comparing the results, looking for staging. So again, in a stage 3 patient, we had a Fib4 of 2.74. That was intermediate. With our cirrhotic patient, it came back at 3.36. Our ELF scores were different, of course, 9.9 versus 11.4, and that was diagnostic for stage 3, and the 11.4 was stage 4. And then for our transient elastography, we have the 11 kilopascals, which was stage 3 fibrosis, versus our 21 kilopascals, which is diagnostic for cirrhosis. And our CAP scores that we already talked about. So comparing these two particular patients in terms of management, I'm still doing HCC screening for both of them. We're having very serious conversations about the extent of their liver disease. However, we do have, an additional a medication that's available for our stage 3 patient that's indicated for treatment of MASH. So that's really important. And then I'm looking for the, stage 4 patient. I looked for clinically significant portal hypertension. I could look for that in our stage 3 patient as well, using the FibroScan and the platelets, and he would not meet criteria for clinically significant portal hypertension. Telling the difference between stage 3 and stage 4, what do I most typically use to differentiate the two? We usually get FibroScans on pretty much everybody, so I'm going to have the FibroScan. I will tell you, I don't necessarily do a Fib4 on all of my patients because I know that I'm getting the FibroScan. I'll do it. If I'm going to prescribe Resmetirom, I actually do put it in my note because I get it from insurance companies requesting the Fib4, or they're going to calculate the Fib4, so I want to see what it is. But as I said, I do order a lot of MR elastographies as well. And that's often in combination with the FibroScan. So I have more than one non-invasive test that's a little bit more than just using like the ELF and the Fib4. So oftentimes I'll have a FibroScan and an MR elastography, just so that I can confirm. When I have indeterminate non-invasive measures, again, that's another indication for me to get the MR elastography. I have biopsied a few people. We really don't biopsy much anymore for staging in liver disease because we shouldn't have to, but I do get crazy results sometimes. I'll get a FibroScan that says, say, cirrhosis, and then I get an MR elastography that comes back as like really no significant liver disease. And I'm like, what do I do with the two of those? I can look for the variability on the FibroScan to try to help me determine, but I often will give patients an option. I'm like, look, we can, just move forward. Let's give it a year, do your lifestyle modifications, everything. And then let's repeat the testing in 1 year. And then we can see what we have. And I would typically go with an MR elastography as being more reliable than a FibroScan. But I have had to biopsy a couple people. It's almost like now we have so much information, so there's an opportunity for conflicting information. So I've done that and, have come up with some surprising results at times. And then when is HCC surveillance important? For stage 3 fibrosis and stage 4, certainly for cirrhosis, but really for our stage 3 patients, we should be screening for HCC as well. And that's, at least with an ultrasound and alpha-fetoprotein every 6 months. All right, so that wraps up our talk for tonight.